Okay, we're running a little behind. Let's get started today, everybody. Good morning and welcome to an online event brought to you by Parkinson's Community Los Angeles and Abbott. Today we are talking about the role of DBS, deep brain stimulation surgery in Parkinson's treatment. I'm Joe Moeller. I serve on the board of PCLA's directors. For those of you who don't know us, we're a Los Angeles-based nonprofit that supports families living with Parkinson's disease through our free online education events, support groups, information referral programs, and more. All of PCLA's programs are made possible by our generous sponsors like Abbott, and we have Jason, a representative, joining us today. Thank you for your time, Jason, and through donations from the Parkinson's community. If you appreciate the work we do and support we offer, I hope you'll consider making a donation, which you can find on our website, pcla.org. Thank you in advance to those who are able to, and thank you for participating to those who aren't today. Just a few quick notes before we get started. Today we are recording the event for our YouTube channel. You will not be visible during the recording, and everyone attending today will receive a link to follow up and watch the YouTube channel. Please stay muted during the presentation and during the questions unless you're actively asking one. We will have time for questions at the end. You can submit them through the chat box at the bottom of the screen. And if typing is difficult for you, I will look for spoken questions from the audience after we go over the written ones. Please try to keep your questions on topic. Also, please join me in welcoming our speaker today, one of our favorites, Dr. Mason. He is a movement disorders neurologist and assistant professor of neurology, surgery, and neurology at the University of Southern California. He came to SoCal from Boston, where he completed his medical degree at Harvard and his neurology residence at Brigham and Women's Health at Massachusetts General Hospital. Dr. Mason's clinical and research interests are in the use and development of deep brain stimulation as a treatment for movement disorders. We are honored to have Dr. Mason also serve on our PCLA Volunteer Medical Advisory Board. Dr. Mason, thank you for joining us today.
Thank you very much, Joe, and thanks for the kind introduction. It's my honor to serve on the board and to be here today to speak with everybody. So I'm looking forward to taking questions and having this be somewhat of an open dialogue as much as possible, as limited by this kind of format. Hopefully one day we'll be back in person one day soon. And so I've made this presentation relatively short. It shouldn't at all take the whole hour, and we'll look forward to discussion after the presentation. But we can get into it now if I can advance my slides. First of all, no industry representatives have influenced the content of this talk. I have no conflicts of interest related to the content of this talk. Certainly in deep brain stimulation, we have a lot of interactions with industry representatives that are very helpful and productive. And so there is some content from our industry partners in the talk, and I've labeled it as such. It's mostly slides and diagrams that I've adapted, but just for your reference and for your knowledge. I'd like to talk just briefly about the history of deep brain stimulation today, because it's interesting. I'm going to talk about how DBS works in the brain, and then factors to consider in your decision to pursue DBS, whether it's appropriate for you. So who, the what to expect, when DBS might be appropriate. And then we'll talk about some choices related to deep brain stimulation that you would have to make if you decided to pursue that option, specifically where in the brain to stimulate and how to undergo the surgery and what kind of device that you might like to choose. And all of these decisions would be made in concert with your physician. And then we'll talk briefly about some new and future innovations in the DBS field that I think are exciting. So the history of deep brain stimulation really goes back to the 30s. Some of you might have heard the name Wilder Penfield, who did some very important experiments looking at electrical stimulation of the brain at the Montreal Neurologic Institute. So I'm proud of that as a Canadian. And the field of functional neurosurgery, which is what the surgeons who implant DBS train in functional neurosurgery, started with the development of what's called the stereotactic frame in the 40s. That gave us the ability to perform surgery on the brain without exposing those parts of the brain, starting on the outside of the brain, using precise measurements, and getting into the deeper parts of the brain only through small holes and by instruments that could reach deeply and very precisely. So using those kinds of techniques, the field originated with what are called lesional surgeries. So those are procedures where the surgeon would go in and in some way damage part of the brain to have a therapeutic effect. You can do this by freezing or burning in various ways now. But in the 80s, Benabid performed the first procedure using deep brain stimulation, specifically of the thalamus, to treat tremor. And through the 80s and early 90s, the development of DBS progressed until it was approved formally by the FDA in 2002 for the treatment of Parkinson's disease. So people often ask me if this is a new or experimental therapy. And so I refer them back to this history to say that, no, this is a therapy that's really grounded in almost 100 years of neurosurgical technique. And in 20 years of really safe, 20 years of FDA approved practice, but 30 to 40 years of very safe procedures. So it's one that's very well established. It's a therapy that's very well established. Also important, not only in the history, but to go into how deep brain stimulation functions, because those are the other categories of questions that I often get early in discussions with people who are considering this. So this is a deep brain stimulation system. It consists of three components. The first is the battery, basically, but the formal name for that battery is the implantable pulse generator. That's because it's implanted in the chest and it generates electrical pulses, so nothing complicated there. It's connected to a wire that runs up the side of the neck and then connects to two electrodes. So these electrodes, or here they're labeled leads, are the part of the system that actually delivers the electricity precisely to the area of the brain that we're targeting. And they can be designed in different ways, but you see the electricity here can flow out of this lead, which is about the thickness of a strand of spaghetti or even angel hair pasta. The electricity can flow out of the lead at one of various places, and everywhere you see one of these black lines is somewhere the electricity can flow out, and that gives us the ability to target the electricity. And here you see that these contacts on the lead, in this case, have been split into segments like a pie. And this allows us even more precision in the way that we deliver that electricity. So I'll talk about that later in the presentation. Parkinson's disease causes changes in the brain's response to medications. So many of you are aware that as Parkinson's disease progresses, or as you've had Parkinson's disease for more years, the symptoms might change and the response to each medication dose might change as well. So early after diagnosis, a single dose of medication might work very, very well for 4 to 6 hours without any wearing off of the effect of that dose. And in addition, there's none of these excess movements that you see sometimes in Parkinson's disease that typically occur at the peak of that medication dose, somewhere between 1 and 2 hours typically into the dose of medication. So those excess dancing movements are called dyskinesias. There's a misconception that the medicine itself causes those dyskinesias. And so I like to show this figure to explain that it really is a change in the way that the brain is responding to medications, rather than a side effect of the medication itself that causes these dyskinesias and wearing off periods or motor fluctuations. So you see here in the diagram, in early Parkinson's disease, say 1, 2, and 5 years after diagnosis, each medication dose, represented by this red line and this little tablet here, leads to a rise in the concentration of the medication in the blood, and then a fall, and a rise and a fall throughout the day. As long as you're in this blue period, you have good time where you don't have as much stiffness or slowness or tremor, but you're not in this upper pink period where you have excess movement, the concentration of the medication causing excess movement, and you're not in this period where you have slowness and stiffness, maybe the symptoms that you had before you were diagnosed that went away after you started on a medicine like Sinemet or carbidopa, levodopa. So with each dose of these medications, the concentration in the blood rises and falls, but you're still in this blue area. So you'll notice that as we go on towards the right, this figure is representing the change in Parkinson's disease as a narrowing of this blue area. This blue area is what we call the on time without dyskinesia, and sometimes the therapeutic window, people might refer to it. But this is the area that you need to be in to feel just the way you want to feel, nice and loose, easy and fast movements, maybe a quick walking speed, but you don't have too much movement. You're not in this upper zone of excess movement. So here, even though each dose of medication is doing pretty much exactly the same thing, it's coming to the same highest concentration and it's going down to the same lowest concentration as it did before, that blue zone has changed. And so what you end up developing is a little bit of excess movement and then a little bit of wearing off in this hour or so. And as the disease changes further over time, the window narrows further. And so somebody might spend more time of the day with bothersome excess movements and with slowness of movement. And it's important to understand that this is the disease changing over time rather than any side effect of the medication. So then what does DBS do at specifically at around this point, which is I'll talk about in a little bit, but where we might consider using deep brain stimulation to improve somebody's symptoms? What does DBS do? Well, DBS takes this narrow window and enlarges it again. Okay, it's an analogy, and we don't know exactly why or how this works, and we're still trying to figure out the mechanism of deep brain stimulation. But these swings in responses to medications stay the same, but the therapeutic window changes. And so you end up spending more time of your day in that good period where you have looseness and easy movements without excess movements and without slowness or tremor. Okay, so I hope that makes sense to everybody that DBS is not reversing anything with the disease. It's not changing the way that the disease progresses, but it is changing the way that the brain responds to each dose of medication, okay? I don't want to give the misconception that it's bringing the disease back to an earlier stage, but it is expanding that window where you have good symptom control without excess movement. That's an important concept to understand. So that's how deep brain stimulation works. Now we'll go into some of the factors to consider when you're thinking about whether you might be a good candidate for deep brain stimulation or whether it might be helpful for you. First, we'll start with the who. Am I a candidate? This is the most important question. You know, these specific symptoms, I've had the disease for this amount of time. Do you think that this would be the right therapy for me? So there's a few key factors to consider in that question of who. First is that you have a diagnosis of Parkinson's disease. And there's diseases that look like Parkinson's disease that are different, like Lewy body disease or multiple system atrophy, for example. And those we would almost always say deep brain stimulation is not the right solution. The second is that the symptoms began more than 5 years ago. And the reason for this is that some of those other diseases can look a lot like Parkinson's disease early in the disease. So for the first 5 years, we may not have a definite answer as to whether something is Parkinson's disease or one of these other similar diseases. And so we'll wait those 5 years typically, even if you have fluctuations in your symptoms and excess movements. The third is that your symptoms have responded and do continue to respond to some degree to medications. And the fourth is that you have these fluctuations, these on-off periods, times in the day where you feel good and other times where you feel slow and stiff and tremulous or having tremor. Or you may have excess movements, dyskinesias, that are bothersome to you or that impair your function or impair your social functioning you find embarrassing for any reason. Some people find that they're bothersome and others do not. The fifth is that the symptoms which respond to the medications, and I hinted at this, are the symptoms which are impairing your quality of life. So you may have a broad set of symptoms, some of which are very bothersome to you and respond to medications, and others that may or may not be bothersome but don't. And we want to make sure that there's a good match between the symptoms that bother you and the symptoms that respond to medications, because we know that the deep brain stimulation, and I'll get into this, is going to treat those symptoms that respond to the medications, typically not those symptoms that do not respond to medications. And the sixth is that some people are unable to take medications due to side effects, nausea, severe nausea, sometimes dizziness when standing. And in those people who are unable to take medications for Parkinson's disease, but would have some benefit from them, were they able to take medications, deep brain stimulation could also be a good solution. So what to expect from deep brain stimulation, and you'll have a conversation with your neurologist about this very question. It really is unique to each person. And it's important to have a discussion with your specialist or movement disorder specialist or your neurologist about which of the symptoms will be likely to respond to stimulation. Gait problems, walking problems, and balance, for example, are two categories of symptoms that tend not to respond to DBS. How likely is it to be beneficial? Well, in the correct population of people, that is the people that we've chosen carefully to undergo the surgery after these types of discussions, there's a very high likelihood of improvement. Somewhere in greater than 90% is a rough estimate. And how much? Well, it really, again, does depend on the symptoms. So in terms of what to expect, there are a few rules of thumb, and I've hinted at these already. But again, because it's very important to reinforce, the symptoms which improve with medications, and especially those symptoms which tend to fluctuate with each dose of medication, are the same symptoms that are going to respond best to DBS, and the ones that we would hope to maintain at that steady state throughout the day. Second rule of thumb is that the stimulation is never going to do better than the medications. So your best on time, when you're feeling the best at whatever point in the day, early afternoon after you've had a couple doses of medications, that's the best that the surgery can do. And the flip side of that is that the symptoms which tend to persist at those times, like for example, balance problems or walking problems, those would tend not to improve with the stimulation. The one exception being tremor. So tremor is a very special symptom in this way that sometimes the medications don't really improve it at all, or improve it minimally. And deep brain stimulation can give a very significant additional improvement in tremor control over and above medications. But pretty much every other symptom, the rule of thumb is the best the meds do is the best that the deep brain stimulation can do. The flip side of benefits is side effects and risks. So you'll talk to these with your specialist or with a surgeon before you decide to undergo any procedure. But as a rough estimate, the risks and side effects of surgery related to hardware in the surgery itself are in and around 1 to 4%. So there's about a 2 to 3% risk, 2 to 3 out of 100 of bleeding in the brain, but most of the time that bleeding doesn't cause any symptoms. There's also about a 2 to 5% long-term risk of infection related to implanting the hardware, and around a 2% to 3% risk of poor positioning of the lead, which is lower, I would say, in the modern era, especially when we can direct the electricity with these new devices in different areas. We can get around some imprecise positioning of the electrode in the brain. And then fracture malfunction of the system in and around 2 to 5%. The electricity itself can also cause side effects, but almost always these are temporary side effects, and they would go away when we turn the stimulation off. They would also go away with some careful reprogramming of the device. So if there's a side effect that's bothering you from the stimulation, you would go and see your movement disorder specialist, your DBS neurologist, and you would work with them to reprogram the device, try to obtain good symptom control without those side effects. So the patient journey, so to speak, what are you actually going to have happen in the process of getting the deep brain stimulation, and how does it take? Well, the whole thing, from the first time that you meet with a specialist to a point where you're feeling like the DBS is really cooking and working for you, that's going to be probably about 8 months. Okay, but we can break that down. The initial evaluation will take you about a month to get in to see somebody after booking the appointment. You'll see usually a neurologist and a neurosurgeon, sometimes at the same time, sometimes at different times, to talk about the procedure and whether you'd be a good candidate. Then you'll see a neuropsychologist to undergo a full battery of tests on your thinking and your emotional state and any psychiatric history that you've had, really because we want to make sure that there's no impairment or problems with your thinking that would become issues in the future. Because DBS in some cases rarely can worsen thinking problems, and it will definitely never help them. So we want to make sure that those things are not impairing your quality of life, or can be expected to impair your quality of life in the near future. So all that being done, you'll come back for the surgery. It's usually a couple months between the evaluation and the surgery. So now we're at about 3 months. The surgery is a day surgery. We'll talk more about it in a few minutes. Then you'll come back usually a couple weeks later after the first surgery to have the battery placed in the chest. That's the second stage, and that's usually a day surgery. It just requires a simple incision and placing the battery and connecting it up to the wires and the electrodes that have been implanted in the brain. Then we wait an additional 2 weeks for all the inflammation and healing to inflammation to go down and healing to take place, and perform the turn the device on and perform the initial preliminary programming. And then we'll see you again every couple of weeks or month or so for the next few months to fine tune the programming. So most of the benefit that you see after the DBS device has been turned on occurs in the first 3 months, although there is some incremental benefit probably over the next 6 months as things get further fine tuned. So if you add that all up, about 3 months till the end of the first surgery, a month until the programming, and then another 3 months, we're at about 6-7 months. So that's sort of a long process, but it is a careful process, and that's why it takes us a long time to get through it in a safe and thorough way. So when should I consider DBS? Am I at the right point? If I fulfill all those sorts of criteria, should I pull the trigger now or should I wait? Well, the best time is usually when you're in this zone of so to speak, moderate Parkinson disease. But if you just think back to those criteria, there's no age cutoff, and this has been proven through an important trial that was done about 10 years ago. No particular age cutoff. And if you fulfill those criteria, then you're in a good place. If you're getting into some symptoms that don't respond to medications, really impairing your quality of life, such as thinking problems or walking, freezing problems, then it might not be the right time because the DBS is not going to help those problems. But if you're in this zone where the medications work and you have dyskinesias and wearing off, that's exactly that nice middle range where the surgery can be very effective. So the final when question then is, well, how long does the deep brain stimulation last? It's also a common question that I'm asked. It's one that we don't have an exact answer to because we've only been using it for 20, 25 years. And so the patients that we follow have shown us that the deep brain stimulation continues to work as long as we follow them. So some symptoms, though, respond very well over time, and others tend to accumulate despite the stimulation and require changes in medications or the stimulation itself. So when we're talking about the longest duration, of symptom control, we're talking about tremor, stiffness or rigidity, and those motor fluctuations, on-off periods, and excess movements, dyskinesias. Those all tend to be controlled for many, many years. Some symptoms tend to worsen just as a result of the disease changing over time and necessitate medication changes. Those are the bradykinesia, slowness of movements, and then stiffness in the neck and trunk and back. And then there's symptoms, of course, that don't respond at all to the surgery, and those would just continue to not respond to the surgery over time. Posturing, gait problems, freezing, swallowing issues, memory and mood problems. I've talked about those a couple of times so far. So what about the questions of specifics? Where is the stimulation going to go? How are we going to do the surgery? What kind of device am I going to choose? So that's the second category of factors to consider when you're thinking about deep brain stimulation. The electricity can be applied when we're talking about Parkinson's disease in one of three places, and really two are used almost all the time: the GPI, or the globus pallidus interna, and the STN, or subthalamic nucleus. We can also apply the electricity to the thalamus, but that's really just when we have tremor and not a lot of other symptoms. So that's a very specific case. 90% of the time in Parkinson's disease, if not more, we're going to be stimulating in the globus pallidus or the subthalamic nucleus. And these three targets, they have their specific advantages that you can talk to your neurologist about, but this is usually a decision that's made between the neurologist and the neurosurgeon, considering the symptoms that are most bothersome to you. You can certainly be involved in that decision and ask questions about this. The globus pallidus tends to offer a little bit easier control of excess movements and a little bit easier control of those cramping, pulling movements that sometimes occur in Parkinson's disease, especially when you're in an off period. That's dystonia. The subthalamic nucleus allows us to decrease the amount of medications that you're taking, whereas the globus pallidus does not do that. And the thalamus offers a probably superior tremor control to either of the other two targets. But again, it's a very specific situation that we would use thalamus stimulation, or VIM, which is a part of the thalamus. In terms of how to perform the surgery, there are two methods. One is to perform the surgery completely asleep. And in that case, the surgery is guided only by an MRI. And then the other is to have a period of time during the surgery where you're awoken under light anesthesia or sedation and perform physical examination testing. So these two strategies are different ways to make sure that that electrode or lead is getting into the place that we want it, because those targets that I just talked about here are all, about the size of an almond. They're quite small or smaller than that. So we want to do some extra testing and examination or collect extra information to make sure that we're in the right place and we're not putting that electrode in the wrong place. So two ways of doing that. In the asleep method, you're actually in the MRI scanner the entire time. The entire surgery is performed in the MRI suite. So because of that, it needs to be done quite differently. And there are relatively fewer centers that offer this option. So USC is the only center in Southern California that offers this option at the moment. In California, there's also UCSF that offers asleep, entirely MRI guided surgery. The awake surgery has been long established, is very safe, and generally, even though it sounds a little icky and a little difficult, generally people do just fine, and it's comfortable, and we give them medications to relax them. And when we're performing the examination testing, we're talking as if we'd be talking in the clinic. So it is a comfortable environment in that sense, although it can seem, from the outside, and especially hearing about it from the first time, to be a difficult thing. The important thing to know about both of these methods is that they produce the exact same results. The outcomes of the surgeries in terms of symptom control, complications, side effects are very similar. So it really is a conversation about what method you would prefer. The other set of decisions you need to make about the surgery itself, and again, this is one that is often made between the neurologist and the neurosurgeon, is what device you're going to choose. So each one of them have advantages and disadvantages. Each one of them has advantages and disadvantages. At this point in time, they're all more similar than they are different. And that was not the case a couple of years ago. And there certainly are meaningful differences now. But the differences are smaller. So Abbott, Boston Scientific, Medtronic are the three companies that are FDA approved to supply these devices. Just give me 1 second. Make sure that messages I'm receiving on my phone are not about this talk, for example, me being muted and not being able to hear that I'm muted. The advantages of the Abbott device are really that it offers the ability to program the device when you're not in the office. So you can be at home. I, as the DBS specialist, can be in a medical office. I can connect to the device over the internet in a secure portal that is private and protected. And I can actually program that device from a distance. So if you live particularly far away from the center that is implanting the device and where you're seeing the surgeon and the neurosurgeon, then this is a nice option for you. Not a good option for the initial programming. That really should be done in person. And actually, over the first few months, you should certainly come back and be seen in person, because that's when you're really fine tuning. But once you've gotten into a steady state, it's a nice option to have to be able to do that programming from home. The Boston Scientific and Medtronic devices are both very versatile. They both probably offer relatively the most flexibility in terms of the way that the electricity can be applied. They both offer rechargeable and non-rechargeable batteries, which I'll talk about in a second. The disadvantage is that they're both very flexible, but they're both relatively more complicated to program. And so sometimes you have to understand that the neurologist and the movement disorder specialists are human. They have their preferences. And if the programming that they're used to is with a specific device or another, they might favor that device because they're very familiar and very comfortable and very good at using it. So those are the relative advantages and disadvantages. I mean, most centers will offer all three. At USC, we're certainly very comfortable programming all three, as are most major centers. And it's a conversation that you can have with your neurologist and neurosurgeon if you're specifically interested. And if you're not, it's a decision that will be made outside of your input on its own. Sort of that can be on autopilot. A factor that you will be asked about is whether you prefer a rechargeable or a single charge device. So people will call this single charge different things, like a non-rechargeable battery or a primary cell battery. But basically, this is just a normal battery that you need to replace every few years because it runs out of juice. The rechargeable battery, you would need to recharge once a day or once a week, depending on how long you choose to do that. But it needs about an hour to an hour and a half of active charge time per week. So the advantage of a single charge device is convenience. So set it and forget it. Once it's implanted, you don't have to think about it again until the next time it needs to come out and be replaced roughly 3 to 5 years later. Every time you replace that battery, there's a small risk of infection. And the more times you have that replacement done, the higher that risk of infection becomes, because you're just accumulating, more and more instances of a 2% risk. So if you do 5 surgeries with a 2% risk, the overall risk might be somewhere in the realm of 10% of having an infection occur. The rechargeable option, it's smaller, it's a little thinner. So overall, it might be in some people who are very thin, a slightly more comfortable option, although the difference is minimal. The main advantage being it lasts a longer time if you're willing to charge it, and you don't need as many surgeries in order to take it out and replace it. There really is no best option, period. There's no best device. There's no best choice in terms of battery, rechargeable battery versus a single charge battery. There's no best choice in terms of where to apply the stimulation, the STM, the GPI, the thalamus. It's an individualized decision. It's complicated and it's nuanced. It really is dependent entirely on you, your goals, your symptoms, and how the disease has affected you over time. So these are all decisions that you will make together with your neurologist and neurosurgeon, none of which you will have to make alone, some of which you might not even really be interested in making at all, like which device to choose, and you can just let that pass by and leave that to the doctors. So then briefly, with just a couple of minutes and to leave 15, 20 minutes for questions, I'll talk about new and future innovations in this field that are particularly exciting. One I've already hinted at the very beginning of the presentation when I was talking about that electrode or lead that goes into the brain and applies the electricity. So the earlier generation devices applied the electricity in basically a full circle around a single contact. And the electricity goes out in a sphere and it stimulates all of the nerve cells around that sphere. The newer generation of devices, they've split that contact on the electrode into pi pieces, like I said, that allows us to direct the electricity in one of 3 directions. And that allows us to be more selective about what we're stimulating and what we're not. And I think this image demonstrates this well. This is from one of the device companies. So you see here, the blue area is a target in the brain that we're trying to stimulate with electricity, which is shown in purple. The yellow area is an area which is producing side effects that we want to avoid. So by applying the electricity to one or more of these pi piece contacts, we can really determine what the best area is. So here we're sort of not stimulating enough of the blue. So we've redirected it here. We can decrease the amount of electricity to avoid that yellow area and then shift it downwards a little bit really to get it in the perfect place. That's the flexibility that I was talking about being offered by directional stimulation. This was new as of 2-3 years ago. It's being offered by every major center that's offering deep brain stimulation. The second innovation is slightly newer. It's the ability to not only apply electricity, but also to detect the electric signals that are coming from the brain cells themselves. So from that same electrode, not only can we release the electricity, but we can use the electrode as a measuring device and pick up the signals that occur when nerve cells fire. And that allows us to understand the sort of network activity of the group of cells that are surrounding the electrode that we've implanted. That can be very useful because some symptoms correspond to specific signals, and we can try to shape the way that we deliver the electricity according to those signals, and so treat the symptoms, which may or may not be unclear to us from a level of just examining it or seeing the person in person with our eyes. An analogy for this kind of strategy is a thermostat. So by using the input signals from the brain, our ability to sense those signals can allow it to act as a trigger for the way that we deliver the stimulation. Just in the same way that the temperature of the room is a trigger for your thermostat turning on your furnace, the furnace then heats up the room, changes that signal itself, which then feeds back to the thermostat and turns off the furnace. So this loop, this closed loop, so to speak, is one of the holy grails of deep brain stimulation research right now. And there are efforts out of Stanford in particular, but multiple centers across the country to understand how we might be able to use this kind of strategy to treat symptoms in Parkinson's disease, either more effectively or with less energy and battery use, so we don't have to replace the battery quite as much. So this is just one video of this strategy that I wanted to show you briefly, and there's a lot of detail here, so I'm going to kind of skip through. But this is a gentleman with essential tremor. So this is not Parkinson's disease, but it's a tremor disorder that causes difficulty with movements, which you can also treat with stimulation. You can see that there's a lot of tremor movements of his left hand. So when we turn this is a closed loop system. So he has something in the brain that's measuring the activity of the brain, and it's feeding into the electrode itself. So there's a lot of lines here, but the three that are most important are these lines here, which is the signal from the brain it's detecting. This line here, which is the amount of electricity that's actually coming out of that device that's treating the tremor. And this line here, which is the activity of the arm itself. So I'm just going to skip ahead here. So you see here at this point here, his arm has not moved. That's this signal here. It's about to happen. There's about to be a burst of activity from the muscle. But the brain has already triggered the movement to occur. And that brain trigger, which is shown with these blue and yellow lines, has already been detected by the device. And you can see that the electricity is already starting to ramp up even before this person moves his arm. So that by the time he moves the arm, and you see, the device has applied the electricity and there's less tremor. So this is the kind of closed loop, and then he puts his hand to rest, the brain signals change, and the electricity stops. So this is the kind of signal that allows this closed loop system to work, and a really interesting example of how it might work in the future. And the final innovation that I just want to mention briefly is the idea of image-guided programming. So there are already a couple of companies that are offering ways to integrate imaging information into the way that we program the device. So we can take the MRI that you undergo before you have the procedure done or have undergone it at another time, take that, your specific MRI information, and upload it to the programmer so that we can reconstruct in 3 dimensions the areas of the brain that we want to stimulate. And we can show those as an animation on the screen that we see. And we can compare those areas to where we see the electricity going and make sure that everything is going in the right place. And we're not applying the electricity somewhere that's going to cause you problems. We're applying it in a way that's going to alleviate your symptoms. So this is a field that's really, this is a strategy, I'm sorry, that's really only starting to take off. We don't know how much it's going to help because we already have such good efficacy in deep brain stimulation in general. But I think for some tricky symptoms and for some tricky side effects, this is going to be very useful. And it's going to allow us basically to look inside your brain in real time, not in real time, but inside your brain specifically while we're doing the programming in real time in order to understand what we're doing and how to do it best. Not only can we look at the structures of the brain that we normally see on conventional MRIs, but we're now understanding ways of manipulating that MRI information to reconstruct the wiring that connects different areas of the brain that you usually can't see on a typical MRI. And here it's shown, these wires are shown in red and blue. We can also reconstruct those so that we can understand not just the nerve the nerve structures, the anatomical structures that we're stimulating, but also that wiring that might be adjacent. So that offers us an additional piece of information to guide the stimulation, guide the programming. And finally, I did also just want to mention that machine learning algorithms are being used to design ways of doing the programming in an automated fashion. And that might integrate with sensors that you can wear on your body that detect your movements and change the programming in a way that would be predicted to improve the symptoms and in more of an automated fashion. So these are also strategies that are coming into play probably sometime in the next 10 or 15 years, but these are a little farther off. This is our team at USC, Nazrin Esnashari, Jennifer Huey, myself on the neurology side. I'm also sort of a bridge to our three wonderful functional neurosurgeons, Dr. Darren Lee, Dr. Brian Lee, Dr. Mark Leiker. Together, between them, they have a half-century of experience with these techniques. And in particular, Mark Leiker's probably been doing deep brain stimulation as long as anybody in this city for the last 20 years here at USC. And our neuropsychology team, led by Dr. Andrew Petkus. So we try to offer as much of an interdisciplinary approach to the treatment of our patients with Parkinson's disease. We interact with our physical and occupational therapy, which is one of the best in the country, to try to provide an integrated care model and really address all the symptoms that our patients with Parkinson's disease have, not just through deep brain stimulation, but also medications and treatments like physical and occupational therapy. So that's my little plug for our team. It's a wonderful team. And so this is my email address. Let's get to some questions now. And I really hope that I'll hear from you if you have any particular questions in the future.
Thank you, Dr. Mason. That was wonderful. I will get started with the first written questions. The first question we have is from Frank, who is wondering, will DBS help with speech issues during off times?
So I'm going to take us back to those original concepts. Because the medication, the symptoms that respond to medications typically respond well to deep brain stimulation. If your speech problems get better when you take a dose of medication, then it may get better for more time throughout the day. Speech, though, tends to be a symptom which does not respond as well to medications. And so in most people, the deep brain stimulation does not help with speech. And in some cases, there can even be side effects of worsening speech that we need to try to get around with the way that the stimulation is applied. So it's either neutral. It's neutral in the vast majority of cases. It doesn't worsen speech, and it doesn't improve it.
Thank you. Another question from James. Will DBS help with the cognitive issues of PD?
Yeah, excellent question. And at this point, although there are studies of using deep brain stimulation for cognitive symptoms, and we're doing one of them here, studying deep brain stimulation for Alzheimer's disease. Dr. Darren Lee is leading that project. At this point, the clear answer is that deep brain stimulation does not help any of the cognitive or thinking problems that occur in Parkinson's disease. Obviously, we wish that wasn't the case. There was some evidence that stimulating in particular areas might worsen cognition over time, and particular aspects of thinking. That's being studied in another ongoing trial, actually, here at USC. But at this point, we can firmly say that it doesn't help. And we're hoping to get to a point where it does not worsen anything, and it clearly doesn't worsen thinking over time. At this point, we need to be careful about where we apply the electricity and in what way in order to not worsen those thinking problems. And we can usually, again, have it be a neutral treatment. So it doesn't have any effect on thinking one way or another, in a negative or positive way.
Thank you, doctor. Does DBS help relieve muscle cramping?
It can, yeah, it can. So there's different reasons to have cramping. In Parkinson's disease, often in off periods where the medications have worn off, cramping can occur, and it's often due to something called dystonia. If you have off dystonia, it will respond very well to deep brain stimulation. And also, if you have sort of a peak dose dystonia, where you take your medication and the deep brain stimulation, you take your medication and the medication causes a cramping of muscle, that can also sometimes improve with deep brain stimulation. So that's something that your neurologist and neurosurgeon should know.
Okay, what is the main benefit that people get from DBS with PD?
Well, there's no right single answer to that question. I think the stiffness And the stiffness improves very dramatically with DBS. Tremor control improves significantly with DBS, and slowness of movements as well improves, especially early on, very, very well. So all those symptoms can get better, but they're never going to get better than the best your medications can do. They're just going to be in that zone, in that good zone for more time throughout the day. So that's the key thing to understand. There's no one single thing that improves most. It just depends on what your symptoms are.
Thank you, doctor. Those are all of our written questions. Do we have any spoken questions? Please unmute yourself and raise your hand so I can call on you. Doctor, are you seeing any? Sorry, I'm trying to zoom back and forth with all the screens and.
Let me see here, I'll expand. Yeah, it looks like Diane has a question.
Oh, my name's Dennis. It's Diane's computer. I'm Greg Pitt's private nurse, home care worker. He has Parkinson's. He has the deep brain stimulator, but he had it removed due to other health causes where where he was x-rays and other surgery. And so Diane wanted, because she had it removed. He still has one battery because he had both sides, but he's gonna get it put back in. So you ever met a patient who, like Greg, had it removed and is getting it put back in? And is it like the second time, will it be maybe like a little stronger?
So yes, to answer your first question, yes, I've had plenty of patients that have needed to have the stimulation or the device removed, and then I've had it re-implanted, a different device. Right. Typically that tends to be for infection. And it's no more effective the second time. The goal is to have it be as effective as it was the first time.
Okay. Like because he's had Parkinson's, it's getting close to 20 years. When a patient is there, is it any advice where something, because his stimulus, I noticed with a few times it has got turned off because we thought maybe it was because he was near a refrigerator or near a magnetic device. And when I turned it back on, I see how his eyes lit up, and he was talking. And like right now, my prayers are with him because he's actually in the hospital right now. But he talks. He tells I'm alive. The doctors were kind of counting him out, and he let everybody know I'm alive. But I just figured when it gets put back in him, if I'm seeing him talk and be aware, because I guess the doctor, he heard them talking and it maybe scared him or startled him. He was more excited than anything. So when he gets to DBS again, it's going to be a spark, because the doctor also, before he had it removed, had it turned up, and it was like reminiscent of when he first got it.
Yeah, so there's a lot of questions in your question. So I'll say that it definitely works for a long period of time. And even though it's been 20 years since his Parkinson's disease, it probably is still working. And so it'll be important, if it was that effective and you saw such good benefit for him, when they replace it, you'll have to adjust the stimulation probably around some of the changes that have occurred since then, and probably have to start the stimulation in a different way, but bottom line, we'll be able to get him to a point where he has good benefit from that stimulation. He's back a little closer to where he was than where he is now. Yeah, so that's the bottom line there.
Do you recommend it to be higher? Because his was.
Well, I can't make specific recommendations on really anybody's care, but in general, it's good to move cautiously, especially in an older person, and especially when the device is going in after a period of time it's been off.
Oh, okay.
Doctor, thank you very much. Everybody, thank you for joining us today. We have so many great events coming up. Next week, we have a presentation on occupational therapy for Parkinson's. And on the 24th, we'll celebrate our poetry book with a poetry slam event. We have over 30 poets. It's going to be a wonderful experience. If you're able to join us, please do. And a lot of the poets are from patients and people experiencing PD like yourselves. Next month is Parkinson's Awareness Month. We also have a lot going on. On April 29th, Dr. Indu will join us to talk about her recent research into the unmet needs of women living with Parkinson's. We also have an education event on DBS and occupational therapy for Parkinson's, and a really special event, our poetry reading from writers of our community. So please check back in frequently during April. In celebration of Poetry Month, and our forthcoming book of poetry will also be out, and the list of all of these events will be emailed to you. Again, thank you very much for Abbott, who is today's sponsor and made this programming possible, and also by you. By donating to PCLA, you can join us in our mission to improve the lives of families in our community who are living with Parkinson's. PCLA is a nonprofit, and all donations are tax deductible. If you enjoyed today's program, please consider making a donation. The link can be found at pcla.org. And as always, reach out to us with any questions. Our email is info@pcla.org, and our phone number is 310-880-3143. Thank you, everybody, for joining us today. Stay safe.